Hi, this is Ron Rosard. Today we're going to talk about Chapter 34, Chest Trauma. Oh, with this chapter, we're going to dive into the different types of chest trauma that we could possibly see in EMS. Understand that they can be very dramatic, okay? They could be very distracting, but they can also be very small and easily overlooked. We do need to look at chest injuries as a lethal type of injury. It does affect breathing, so therefore does affect things in our primary assessment. So we do need to be aggressive when looking for and treating these injuries. And then we should always have a high index of suspicion based on the mechanism of injury. So let's say if we get a shooting or a stabbing or even a vehicle collision, we should have a high index of suspicion that there's been some kind of injury to the thorax. Now, we're going to talk about the anatomy of the chest. So the chest is also considered the thoracic cavity. Okay, the dividing line between the thoracic cavity and the abdominal cavity is going to be the diaphragm. The vital organs that are contained within that thoracic cavity include your lungs, your great vessels such as the inferior superior vena cava, the aorta, the heart. So a lot of vital organs in that area. And there is some protection that is provided by the ribs there. Now, the thoracic cavity has two layers of pleura. We have the visceral pleura and we have the parietal pleura. Visceral, simply visceral's organ, so visceral pleura, the lining that goes around the lungs. And then the parietal pleura, which is parietal means wall, parietal pleura is going to be on the thoracic wall. All right, so here's kind of a gross overview of your anatomy here. So, like I said, lungs, heart, great vessels are going to be located within the thoracic cavity, trachea, esophagus, all that good stuff. And now it's all encapsulated by the ribs, which provide that protection. All right, now talking about the pleura, you have the visceral and parietal pleura. So you have the visceral pleura, which goes around the lungs, and then the parietal pleura, which goes around the thoracic wall. Now there is a almost suction-like effect because there's a semiserous fluid that is between the visceral pleura and parietal pleura, and it creates a suction or a connection. So when we inhale and that chest wall moves up and out, it actually pulls the lungs open. When the diaphragm contracts and pulls down, it will pull the lungs down to open up the lungs to create a negative pressure in the chest, which causes inhalation. Now, when those muscles all relax and the chest wall comes down, diaphragm moves up, that creates positive pressure in the chest and that pushes air out. Now, the issue happens if we have, say, a open chest wound where air can then flow into the chest. We do create positive pressure in the cavity, which can then collapse the lung, and it actually separates that connection. So different categories of chest injuries. We have open chest injuries and closed chest injuries. Open chest injuries are going to be caused by penetrating trauma. There is a concern with cavitation, so from like gunshot wounds, and the cavitation can be, small if we have a lower velocity round, like like a pistol type round, or it can be really high if you're dealing with, like a hunting rifle. So cavitation, we're not just worried about, the path that the round took through the body, but we're also worried about that rapid expansion of tissue from the transfer of energy that's occurring and tearing and shearing tissue that is surrounding the path of the bullet. Okay, now if one of the great vessels in the chest is injured, it can result in immediate death. So if we're having an injury to the aorta, inferior vena cava, vessels are organs. There's like a trick question on one of your exams. Be on the lookout for it. Where it's like which organ, if injured, will cause rapid death. And vena cava is an option, and liver is an option. And a lot of people, like automatically go to liver because they're like, oh, it's like, well, liver's an organ, and they don't think of the vena cava or the vessel as an organ, and that is it's an organ. So you have to look at that and you have to consider that. If you have a large tube that contains, I mean, the venous system contains about 64% of your blood volume at any given time, you're looking at rapid blood loss if that great vessel is damaged. Okay, so here's an example of an open chest wound. This can look very superficial, and it could be something that you could completely dismiss. No active bleeding. Oh, it's probably not that bad. But if it's penetrated into the cavity and caused damage to the lungs, this patient can still develop, a pneumo and a tension pneumothorax. If there's damage to vessels, a hemothorax. And that patient can deteriorate over time if no intervention is done to treat them. So it can be very small, like what we're seeing here, where you don't see a lot of bleeding. It looks like a very superficial wound, but you do have, an object that is penetrated into the cavity. Now, this will cause air, not necessarily to suck into the chest via that wound. The wound needs to be about 2/3 the size of the trachea to create what we call a sucking chest wound. Uh, but we're still going to have air that, as those lungs expand and fill with air, if the lung's been damaged, we'll have air that'll seep out of that wound and then into that pleural space. All right. Now, with open chest injuries, the injury may involve heart, major blood vessels. We could have a pneumothorax, which is simply air in the thoracic cavity. We can have a hemothorax, which is blood in the thoracic cavity. Penetrating trauma can interfere with the negative pressure needed for inhalation by allowing air to enter through the wound. That is true. Now we talked about there's a certain a size that's needed in order to have that sucking chest wound. But even if it's a small wound that's damaged the lungs, that patient goes to breathe air in, air will escape the lung and enter into that cavity. And as more and more air enters that cavity, it will slowly collapse the lung down. Now, closed chest injuries are going to be more from your blunt trauma, okay? Like a patient gets in an altercation and, has whatever, a knee that's been driven into their chest after they've been, dropped to the ground, or blunt trauma like a patient that's been in a traffic collision and the chest has hit the steering wheel. Okay, any number of things. Blunt trauma, you don't actually have penetration into the chest though. Okay, now this can too also injure the heart, lungs, great vessel. All right. And you could also get what we call a flail chest or a flail segment. We're going to hit on this more, but a flail chest, in a sense, it's broken ribs, but it's multiple broken ribs. 2 or more adjacent ribs broken in 2 or more places. What ends up happening is you have that section that's broken moving in the opposite direction of the chest wall, which will impair ventilation. All right, so on that flail segment, so remember we have 2 or more ribs, okay, adjacent ribs broken in 2 or more places. So you have that section is free floating in the rib cage. So let's say our patient goes to take a breath of air in, the chest wall normally comes up and out. That flail segment will actually move in the opposite direction. So as that chest moves up and out, the flail segment will move down. That'll affect, of course, ventilation. And I mean, if anybody's had a broken bone, movement of that bone site is painful. So these patients aren't going to want to take deep breaths of air in. They're going to have issue with oxygenation, and then any kind of injury that's been caused to the organ below that, like pulmonary contusion, which is just a bruise on the lungs. Those are things that we need to be aware of that can occur that can further affect gas exchange. Here's a nice little picture of what a flail section or a flail segment would look like. Okay, 2 or more adjacent ribs broken in 2 or more places. In a sense, creates a free floating section which will move in the opposite direction of the chest wall. Okay, we call that motion a paradoxical motion. All right, so with a flail segment, you do have effect on pressure. So during inhalation, chest wall moves up and out. That flail segment will move in an opposite direction. Okay, so again, paradoxical motion or movement. That flail segment's moving in opposite direction with the rest of the chest wall. As the chest relaxes and moves down, that flail segment's going to move up. Okay, and you're going to have like bone on bone grinding, which is going to be really painful for that patient. Here's an example of paradoxical motion. So again, just this section that's free floating is going to be moving in opposite directions of the chest wall. All right, now this is showing you guys the effects on ventilation and expansion of lung tissue. So you see this section here, which would normally, as we inhale, we get this section that's not able to fully expand due to compression of lung tissue. All right, so we're not going to have good oxygenation there. All right, now in the old times of EMS, and I've had a lot of great instructors that would tell me, they would, sandbag, back in like the 80s, they would throw like a 5-pound sandbag that they'd use to stabilize a patient's head for C-spine, and throw that on the patient's chest and tape that down. Well, we're no longer doing that because, the whole thought of like securing a weight to your patient's chest to stabilize a flail segment, is kind of counterintuitive. So in a sense, what we try to do is just support ventilations as best as we possibly can. We're not going to place the patient on the injured side. We're not going to try to stabilize the chest section with any kind of restriction chest wall motion devices like a sandbag. All right, but we will consider CPAP for that patient. We will provide positive pressure ventilations for that patient. Uh, we may splint the extremity on that side to help limit motion, but that's kind of about as far as we're going to go. A big priority is going to be focusing on ventilation and oxygenation, more so as it is the actual injury itself. Now, a pulmonary contusion. A pulmonary contusion is simply a bruise on the lungs. You have bleeding that's occurring in the lung tissue. Now, it's surrounding the alveoli and the interstitial space. Ultimately, it impairs our ability to exchange gases. All right, so it impairs our ability to bring oxygen in, let carbon dioxide out. All right, now a patient who has suffered a direct blow or any other blunt trauma to the chest can have a bruise on the chest. Okay, that's very simply put. If you have enough to bruise the outside, probably enough to bruise the inside as far as energy in that trauma goes. All right, so if we're assessing our patient and that patient's having issues with oxygenation, that it's likely that they might have a pulmonary contusion. All right, this is showing you guys a nice little graphic of what's happening. So we have these pulmonary capillaries here. Now, when they've been damaged from trauma, we have bleeding that's occurring. So you're seeing blood leak into the alveolus and then around the alveoli. And that's going to impair our ability to exchange oxygen and carbon dioxide. All right, now a pneumothorax is air thorax pertaining to the chest. So air accumulating in the chest, specifically in the pleural space. All right, so it's happening in the pleural space and it's separating the visceral and parietal pleura, and it's causing the lung to collapse. Now we can get this from a paper bag effect. Okay, now you think paper bag effect, a patient takes a deep breath of air in, and then all of a sudden they have a compression on their chest, like their chest hitting the steering wheel, and they're kind of bearing down. That can cause rupture of lung tissue. Of course, penetrating trauma, that's damaged lung tissue, and a spontaneous pneumothorax, which we'll talk about a little bit more. But a spontaneous pneumothorax is where you have a weakened area of lung tissue that just spontaneously ruptures. All right, and then of course you have the development of air filling the pleural space after that rupture. Now, open pneumothorax, simply put, it's created by penetrating trauma, penetrating wound to the chest wall, causing air to flow into the pleural space. Okay, your job is to cover that wound as soon as you find it with a glove hand and then treat it with an occlusive dressing. All right, so here's your nice little picture or graphic. All right, now this If not treated, I mean, this patient's going to need to go to the hospital to receive definitive care, but we want to stop air from entering in through this wound. That's why we cover it with a gloved hand. So if we can limit the amount of air flowing into this cavity, the better likely chance our patient has for a positive outcome. All right, because we don't want to collapse this lung down and have our patient simply relying on one lung for oxygenation for their entire body. All right, now a tension pneumothorax is where you have that pneumothorax. Tension is referring to pressure. Pneumo again is air and then air in the thorax. So pressure from air in the thorax. That is where you have pressure building up in the thoracic cavity, and now it's beginning to put pressure on the heart. All right, so the heart, aorta, vena cava, they're all being compressed now. And now instead of having this good like lub dub or like the heart contracting down, squeezing blood out, and then relaxing and be able to adequately refill with blood, the heart's being compressed, and so you're only getting smaller contractions and you're not getting adequate refill. So we decrease cardiac output, which results in hypotension, poor ventilation and oxygenation, and severe hypoxia. With these patients, you're going to start to see things like jugular vein distension. If you're seeing tracheal deviation, where the trachea is deviating off to the one side, that is a significant finding that there is a lot of pressure accumulating in that patient's thoracic cavity. So in a sense, you have a shift from midline here. That pressure is becoming so much that it's starting to compress the heart down, and then the heart can't adequately refill to eject blood out, which is causing our hypotension. So here's an example of penetrating trauma. So gunshot wound. Now this is one of those mechanisms where you're going to have a high index of suspicion that my patient has a significant wound. Now, I'll tell you the one thing with this in your assessment, if you're seeing something like this, you should be rolling your patient and checking the back of your patient for an exit wound. Note one thing that you're seeing here is this is a chest tube that's been inserted in the patient. You note the blood that's being drained out. This patient has a hemothorax. All right, like we were just talking with the picture, hemothorax is blood in the pleural space compressing the lung. Now, may be caused from open or closed injuries. In a sense, we're worried about oxygenation, right? Because we're compressing a lung down from blood, but we're also losing blood. So we could have an issue with like hypovolemia as well. While a tension pneumothorax is an obstructive type of shock, we can have, hypovolemia because we no longer have blood in the vessels. We have blood filling the thoracic cavity. Now, some of our signs and symptoms: severe respiratory distress, signs and symptoms of shock, so hypotension. With this, you could see similar signs to like your pneumothorax and tension pneumothorax, which would be diminished or absent lung sounds on the affected side. So these are things to look for in these patients. All right, so here we go. We have the compressed lung. Now, just only thing is here is it's blood, not air. Now, in the field, as EMTs, there's not much we can do for patients to relieve like a tension pneumothorax or a hemothorax. Paramedics, they can perform like needle chest decompression, where they insert a needle into the patient's chest to let the air out. If a patient has a hemothorax, though, a needle isn't going to do much for that. That patient ultimately needs a chest tube to relieve that pressure. All right, so you see an example here, chest tube being inserted for this patient with a thoracic type of injury. All right, looks like that's some lung tissue. It's been exposed out. All right, now traumatic asphyxia. Now that is where you have a compression of the thoracic cavity and we create a backflow of blood. All right, so we compress the heart and we compress the thoracic cavity so much that blood flows backwards. All right, So with traumatic asphyxiation, we're going to see jugular vein distension. We're going to see, like purple, like lips. We're going to see we see bulging of the eyes. We can have, crackles, pulmonary edema that's occurring from blood backing up from the left ventricle to the lungs. But in a sense, blood is flowing backwards in the body. Okay, and that's due to that rapid compression of the thoracic wall. All right, now cardiac contusion. So just like a pulmonary contusion was a bruise on the lungs, a cardiac contusion is a bruise on the heart. Now this is associated with a blunt trauma, so a closed chest injury. Okay, now that bruise on the heart wall will form. Now the heart may rupture, and that can disrupt electrical conduction, which can cause some cardiac dysrhythmia. So our patient can go into, an arrhythmia, and it could be a lethal one where like the patient goes into like VTAC or VFib, and now you need to do CPR on the patient just from the blunt trauma. All right, commotio cordis. Now, this is kind of one of those things that we just talked about with the cardiac contusion, where the patient can go into a dysrhythmia. But commotio cordis is where the heart has been hit at a weak state. Okay, so it's hit at some point in the cardiac's electrical activity where that blow to the chest causes the patient to go into sudden cardiac arrest. We see this a lot in kids, like little league kids playing baseball. Like everybody wants their kid to play pitcher or wants their kid to play infield, and then that kid takes a line drive to the chest, and they go into cardiac arrest because of the sudden trauma, and the heart was just hit at the right time to cause that child to go into CPR, or not in CPR, into cardiac arrest. Now, CPR is going to be your treatment and applying the AED and shocking the patient if it's a shockable rhythm. Now, pericardial tamponade. Now, what this is where you have bleeding that's occurring within the pericardial sac, and it is compressing the heart. Now, you can get similar symptoms to that of like a pneumothorax, where you get decreased blood pressure, you get jugular vein distension from pressure being put on the heart. However, you do not have like a lot of the pulmonary signs or symptoms. So with a pericardial tamponade, your lung sounds will be clear on this patient because hey, both the lungs are working. Even though you see jugular vein distension, the patient may have suffered a blunt trauma to the chest. Lung sounds are clear, but you see jugular vein distension, the patient's blood pressure is dropping. You might think maybe it's a lung, but if lung sounds are clear and you're seeing these signs and symptoms, maybe it's pericardial tamponade where there's fluid leaking around the heart or blood leaking around the heart, and that's compressing the heart down, which is ultimately reducing your cardiac output. All right, so signs and symptoms, jugular vein distension, signs and symptoms of shock, so cool pale clammy skin, hypotension. Um, Now, with this, dilated pupils, you can see tachycardia, narrowing of pulse pressure. Okay, so remember that's when you're systolic and diastolic. The difference between the two is less than 25% of the systolic pressure. All right, and then radial pulses that diminish on inhalation because as we're inhaling, the lungs are expanding. That could put some pressure on the heart. Now, if we have a pericardial tamponade where we're compressing the heart more from fluid, that'll cause our pulses to go absent when we take a breath of air in. All right, now rib injuries. So rib injuries are painful. If you've ever broken a rib, it hurts to breathe, it hurts to talk, it hurts to do anything. All right. So with these, they can cause some hypoxia because these patients aren't going to want to take a deep breath of air in. Now, rib fractures are not as common in kids as they are adults because kids are, lack of better words, are more pliable. They have more collagen in their bones, so their bones are less prone to fracture. Now, with this, some of the signs and symptoms that you can see, of course, are going to be pain with movement and breathing, okay, crepitation, Tenderness on palpation, so if you're pushing down on it, and deformity to the chest wall, they're not going to want to take a deep breath in. They're going to have a cough, and they might be tachypnic, where they're breathing fast. Why? Because they're breathing shallow, so they're trying to make up for that minute ventilation. If they're used to getting, a minute ventilation of 6 liters a minute, breathing at 12 times a minute, but now they can't get that full volume with each breath. They might have to bump up their breathing to 24 to try to get that same minute ventilation because they're breathing more shallow. All right, now showing you pictures of a rib injury here, but I want you to take note. You guys might kind of see this already. So we have 2 or more ribs that are broken. These are adjacent ribs. They're broken in 2 or more places. So we can consider this rib injury a flail segment. 2 or more adjacent ribs broken in 2 or more places. All right, so click on the injury that is characterized by air trapped in the pleural space under pressure, resulting in compression of the structures of the affected side, mediastinum, and opposite side of the chest. All right, so we're talking about air trapped in the pleural space. All right, so air. So we know we can get rid of hemothorax. We know we can get rid of pericardial tamponade because pericardial tamponade is where it's occurring in the pericardial sac. Okay. Now, sucking chest wound, okay, is an open chest injury, but that can cause a pneumothorax, that can cause a hemothorax, but that's not necessarily what we're talking about here. So, ultimately, it leaves us with only one good answer. All right, and that's B, a tension pneumothorax. So tension is specifically referring to pressure, pneumo is referring to air, okay, thorax pertaining to the thoracic cavity. So we combine all those things. Tension pneumothorax is where you have so much air that is accumulating in that thoracic cavity on that injured side that it is pushing everything to the opposite side. All right, so if I have penetrating trauma on the right and I have a tension pneumothorax that's developed, it's going to start pushing everything over to the left. All right, I'll see tracheal deviation to the left. Lung sounds are going to be diminished on the right because that's where my injury is. All right, but that is what we're looking at here with this question. All right, so when you're approaching these things, when you're sizing the scene, a lot of times, violence is a causative factor to these injuries. So if you have a call that sounds like it could be assault, all right, or it sounds like it's a little sketch, have law enforcement be there. Have law enforcement enter the scene first to clear your scene. All right, utilize standard precautions when dealing with these patients. You may want to wear a mask. Now is 2021. Everybody has to wear a mask now, but there was a time when that wasn't the case. Now, if we ever go back to that, you may want to wear a mask for these patients because they might be coughing. They might be coughing up blood. Last thing you want to do is get that stuff, on or near your own mouth. All right, so some of the different mechanisms of injuries, of course, sports accidents, falls or fights, gunshot wounds, stabbings, vehicle collisions, crush injuries, where patients have been entrapped, or explosions. Now, explosions, we're not just worried about, the shrapnel. We're worried about the pressure wave. That pressure wave can cause some damage to those hollow cavities that we have, and that can rupture lung tissue too. So if you have a patient that's been in a blast, and you don't have any external injuries that you could see, you should still be, having a high index of suspicion that there's something injured inside of that patient. All right, so your primary assessment. Now, use spinal stabilization if indicated. So if your patient meets that criteria to be immobilized, go ahead and immobilize the spine. Now, we're going into more spine motion restriction now versus complete spine motion immobilization. All right, so just if it's indicated, make sure you're protecting it. Now, form a general impression, age, sex, position, surroundings, distress level. What am I seeing in the surroundings with, my mechanism of injury, things that would elevate your index of suspicion. Like, does this patient appear to be in respiratory distress as I'm walking up, versus is this patient just kind of sitting back and talking? Okay. Now, in that primary assessment, make sure your airway is good and expose and examine the chest. If you get dispatched to a patient that's been shot, all right, go ahead and expose and examine the chest then in your primary assessment under your breathing. Of course, you're looking at rate, tidal volume, and effort. All right, but you're also going to want to look for injuries, and you're going to want to treat those injuries right then and there. Not only that, but you're also going to want to roll or inspect the patient's back for any exit wounds. All right, assess mental status, get a good baseline for how your patient is doing mentally. Are they alert and oriented ×4? Because those patients with hypoxia can deteriorate on you, as far as mental status goes. All right, now, if breathing is adequate, apply oxygen as needed. All right, remember, we're just trying to maintain an SpO2 greater than or equal to 94%. Now, CPAP, continuous positive airway pressure, it is great because it will help give that little extra bit of push for patients with flail segment or pulmonary contusion. So it's good to help really get those alveoli inflated to promote gas exchange. If you have fluid accumulating in the lungs, it'll help push against that fluid and help displace some of that fluid to promote gas exchange. Now, if we have a pneumothorax, we are not going to want to use CPAP. Now remember, we can find a pneumothorax if we have lung sounds clear on one side and we have absent or diminished lung sounds on the opposite side. That's where we're looking more, okay, it's a pneumohemothorax now on that patient. We're not going to use CPAP for those patients. All right. Now, if breathing is inadequate, provide positive pressure ventilations. All right. You are going to promote, good full ventilations for that patient. Now, tension pneumothorax results in increasing difficulty in ventilating the patient. So it might get harder for you to squeeze that bag to promote gas exchange. All right. Now, cyanosis is an indicator of poor oxygenation and ventilation. So if you start to see, bluing around the lips or around the mouth, bluing in the fingertips, okay, those are early signs, for that patient's hypoxia is getting worse. Like you showed up on scene, they were a little pale, they were diaphoretic, they were breathing a little fast, and their heart rate was going. And now you have them on like a nasal cannula or non-rebreather mask, and you're assessing them, and all of a sudden they start to go blue on you. All right, that's letting you know, even though you're treating them with oxygen, that oxygen is not getting to where you need it to go, all right, to the alveoli to get into the bloodstream. So now switch over from your non-rebreather to your bag valve mask and ventilate that patient. All right, pallor can indicate early hypoxia, so pale skin. All right, poor pumping of the heart or blood loss. A weak, rapid pulse can indicate bleeding or compression of the heart. And then chest injury patients are a high priority for transport. Okay, so these are going to be your critical, fix what you need to on scene and then transport and then work on everything else en route. Because you're not going to want to limit scene times. These patients, a lot of time, may be surgical patients where, like definitive care is not going to be you on the side of the road. Definitive care is going to be them at a trauma center being treated. So, fix what you need to, cover up open chest wounds, ventilate the patient if needed, but then get the patient in the ambulance and get them to the appropriate facility. Now, a secondary assessment. Perform a rapid secondary assessment. So rapid, your rapid trauma assessment is your quick head to toe to identify any other injuries, specifically any other live threats. Okay. Assess for subcutaneous emphysema. That's where you have air accumulating underneath the skin, jugular vein distension, or tracheal deviation. Now, if you do have a patient where you initially suspected spinal injury and you're holding that C-spine, then go ahead and apply a collar to that patient after you've assessed the patient's neck. All right, now here's the thing. Expose the chest if not already done. But if you've been dispatched to a patient with a chest injury, that is something that should have already been done in your primary assessment. All right, if you have, in your chief complaint, I was shot in the chest, bro. I was stabbed in the chest. All right. You guys should be exposing the chest in your primary. But if it hasn't been done, do it now. All right. Do it in your rapid trauma assessment. Examine lateral and posterior chest. Immediately seal open chest wounds with an occlusive dressing. So occlusive dressing is a non-porous dressing, which does not allow air to move through it. All right. And now for signs of a flail segment with inadequate breathing, positive pressure ventilations. Remember, flail segment, we're not, bandaging, we're not doing anything like that. We're simply supporting ventilation. All right, look for equal rise and fall of the chest. Look for the chest to be moving in opposite directions. Look for swelling, deformity, crepitation, or guarding of the ribs, where the patient's kind of covering up their side. Make sure you're auscultating lung sounds. All right, the patient with a pulmonary contusion might have a little bit of crackles going on. Patient with a pneumothorax might have diminished or absent lung sounds on one side. All right, assess baseline vitals and then reassess those vital signs every 5 minutes. Okay, and then obtain a history on the patient. Now, with your history, just understand that a lot of these chest traumas, if a patient has a heart condition, that can exacerbate that heart condition. If the patient's becoming hypoxic from a lung injury, that could exacerbate a heart condition. All right, so understand that assessing your history might lead you down a road where it's like, all right, this is why like this patient is getting worse, like even though I performed intervention, because your patient that had a broken rib from a car accident, and you're treating him on a BLS level, and you're like, man, why are they not getting better? I'm giving oxygen. Well, they could have AFib and have gone back into AFib because of poor oxygenation or from the trauma itself. So now you have a medical condition that's been brought up from this trauma. So the history can kind of help guide you a little bit of like, what's going on with the patient, why they might not be getting better, even if intervention's been performed. So with these signs and symptoms, things that you might see: cyanosis, dyspnea or difficulty breathing, tachypnea or bradypnea, where they're breathing fast or slow, signs of injury, hemoptysis, where they're coughing up blood, signs of shock, tracheal deviation. If you guys are seeing tracheal deviation, understand that's a very bad sign, right? Your patient definitely has a tension pneumothorax, and you hopefully should have ALS come in to decompress the patient's chest, or be very close to a trauma center or ER where they can insert a chest tube. All right, paradoxical movement, which is that chest wall moving in opposite directions from a flail segment, open chest wounds, subcutaneous emphysema, which is air accumulating underneath the skin, jugular vein distension, absent or decreased breath sounds, especially on one side. Okay, pain at the site of injury, more so with inhalation, failure of the chest to expand normally, now weak or absent peripheral pulses, and then a drop in systolic BP of greater than or equal to 10 millimeters of mercury on inhalation. That is called pulsus paradoxus. So where they're breathing in and the blood pressure drops. So as you're assessing that blood pressure, let's say you were hearing that first Korsakoff sound, right? That represents their systolic pressure. And then they go to take a breath of air in, and all of a sudden you stop hearing it, and you stop hearing it for greater than 10 millimeters of mercury, and then it comes back again. That's pulsus paradoxus, and that is letting you know that there's an increase of intrathoracic pressure. All right, so those are all things to kind of look for when you're assessing your patient. Now, with pain at the site of injury, now pericardial tamponade, where you have a patient that has blood or fluid leaking in the pericardial sac. These patients, they might have more pain laying down, and then when you sit them up, their pain kind of decreases. So that's also something like positional pain with pericardial tamponade, where more pain when laying flat, and then they sit up, and then their pain's decreased. All right, so general emergency care for chest trauma: maintain your ABCs, maintain adequate oxygenation, constantly reevaluate your breathing status. Okay, it's very important because these patients, as they lose the ability to oxygenate on their own, let's say from poor ventilation, like they're just not able to take full breaths of air in, you're assessing this patient, and while they were doing okay on your non-rebreather mask, now they're starting to get pale and blue. All right, that's a big warning sign for you to start, ventilating the patient now to get good, expansion of the lungs, get good oxygenation. All right, there we go. Positive pressure ventilation for the patient. Showing you guys a little discoloration here, bruising. All right, so positive pressure ventilation, this patient was breathing inadequately. They need to promote good oxygenation by ventilating that patient. All right, impaled objects. We will leave impaled objects in place and we will stabilize them. So bulky dressings, around the impaled object to limit motion. Okay, spine motion restriction if indicated, and then treat for shock. So treat for shock, lay the patient in a supine position, cover the patient, keep them warm, and good oxygenation. Now, with open chest wounds, you are going to immediately cover those open chest wounds as you find them with a gloved hand, and then you're going to apply an occlusive dressing over that. Now, once you have that occlusive dressing on, you're going to tape that occlusive dressing on 3 sides in order to have a flap. All right, now continuously assess respiratory status. So be alert to signs of a developing tension pneumothorax. So of those signs, a big one that, your book doesn't necessarily say, but progressive respiratory distress. Like your patient was a little short of breath because, he had a chest injury, an open chest injury. A little short of breath, but he was doing okay. You were monitoring his oxygen levels, and he was around 95% on room air. And now now he's talking 2 to 3 word sentences. Now his O2 sats are dropping down to 90. All right. Now his jugular veins are starting to get all distended. All right. That progressive respiratory distress, all right, is letting you know that maybe that pneumothorax that you had is developing now into a tension pneumothorax. Now, while we need paramedics to really truly decompress that with like a needle in their chest, one thing that we can do is what we call burping the wound. So what you'll do, because that seal that you have on the patient's chest might not be allowing air to escape, and so when the patient inhales, you keep it covered, and as they exhale, you're going to go ahead and lift up on that chest seal that you have, and the hope is that air escapes, okay, and it can help relieve a little bit of the pressure that's building up. Will it always happen? No, but that is one thing that we can do at a basic level to help relieve the tension. All right, flail segments. Remember, we do not splint the chest wall in any way that interferes with chest movement. So we're not bulky dressings, anything like that. Simply maintaining oxygenation. CPAP works great for these patients, and positive pressure ventilations as clinically indicated. All right, there we go, sling and swab. Now this would be good for that flail segment or for that rib injury. Why? Because it limits motion to the arm, not the chest wall, to the arm, which if you try to move your arm right now, like move it at the shoulder, up, down, left, right, I guarantee you're going to feel all those muscles on that side of your chest moving around too, and it's going to cause pain, which is going to further affect their ability to breathe. Okay, now with reassessment, just be aggressive with reassessing these patients. Reassess all your interventions and reassess important steps that pertain to the patient, like a chest assessment. All right, like, do I need to do another full head to toe on this patient after I've already done one? No, but should I reassess the chest and those injuries that I've treated to make sure that my chest is still on the patient? I don't know if anybody's ever tried to put, tape onto something that's soaking wet, but tape doesn't stick well to wet things. All right. Well, if you have a diaphoretic patient, all right, well, that chest seal might not stick great. There are only a few chest seals that I've actually interacted with, more military, so that really stick great even if the patient's sweating. And a lot of the other ones, don't have great adhesion to the skin if the patient's really diaphoretic. So recheck those interventions to make sure they're still in place. Okay, recheck oxygenation, recheck your vital signs. Look for that narrowing pulse pressure. Look for the dropping blood pressure with your patient. All right. So, in conclusion, chest injuries can lead to respiratory compromise, poor ventilation, and poor oxygenation. An open chest wound, in a sense, can allow air to enter into the pleural space from that hole. All right, now in order for it to have that sucking effect, remember it needs to be a little bit larger, about 2/3 the size of the trachea to have that like sucking chest wound type effect. Now, flail chest interferes with ventilation and oxygenation because that flailed segment is going to move in the opposite direction of the chest wall as the patient breathes. Now we're going to immediately cover any open chest wounds with a gloved hand and then occlusive dressing taped on 3 sides. Patients with flail chest or pulmonary contusion may need CPAP or positive pressure ventilations to promote oxygenation. And then we will never use CPAP for patients with a pneumothorax. Remember, if you have that trauma patient with a chest injury and you're assessing lung sounds and they're diminished on one side, they're absent on one side, all right, just know that they're probably developing a pneumothorax or a hemothorax, and we will not be using CPAP for those patients. All right, that concludes this class. I hope you guys have a great day.